In skeletal scintigraphy, the visual evidence displayed on a monitor frequently contradicts the physiological reality of the patient. These three clinical scenarios illustrate the discrepancy. On the left, the glowing uptake in the stomach suggests a technical error, but it is actually a specific chemical artifact. In the middle, the image shows massive, expanding skeletal lesions. While this appears to show aggressive tumor growth, it is actually a sign of rapid bone healing. And on the right, the skeleton appears uniform and clean, an image that often indicates terminal systemic collapse. These outcomes are determined by the tracer itself. Technetium-99m methylene diphosphonate does not map the disease, it maps osteoblastic activity and localized blood flow. Through chemisorption, the MDP molecule binds directly to the crystalline hydroxyapatite in the bone. This binding occurs strictly at the mineralization front, immediately adjacent to the bone-building osteoblasts. Because the skeleton responds to almost any insult, from a benign fracture to a malignant tumor, by producing more bone, the scan is highly sensitive, but it cannot distinguish between these processes based on uptake alone. Accurate interpretation requires looking past the immediate bright spots to identify the systemic signals that define the patient's actual clinical state. Preparation artifacts occur before the tracer ever reaches the patient, often resulting in misleading extraskeletal uptake. The scan relies on a specific chemical preparation, where a kit containing MDP is mixed with ions to properly bind the radioactive isotope. Inside the syringe, stannous ion acts as a reducing agent, successfully tagging free pertechnetate to the MDP molecule. But if stannous ion is insufficient, the reaction remains incomplete. This leaves unbound pertechnetate, known as free TC, circulating independently in the bloodstream. Lacking the MDP delivery vehicle, this unbound free TC bypasses the skeletal system entirely. Instead, it produces a specific diagnostic signature on the clinical scan. The errant tracer localizes in the stomach, the thyroid, and the salivary glands. Recognizing this error prevents a diagnostician from misidentifying benign gastric or glandular uptake as metastatic disease. In oncologic monitoring, a second failure state, known as the flare phenomenon, can lead to incorrect treatment assessments. This occurs in patients with known bone metastases who have recently undergone chemotherapy. Imaging the patient too soon after treatment can yield a scan that appears to show rapid disease progression. This chart tracks tumor volume against tracer uptake. Between 2 weeks and 3 months post-treatment, tumor volume drops, yet the scan shows an increase in hot lesions. This spike in tracer uptake is a robust osteoblastic healing response, not cancer spread. As chemotherapy destroys the tumor, the bone attempts to repair the defect, creating a high-volume sink for the MDP tracer. We verify this by comparing the scan to plain film radiographs taken during the same window. Plain films will show increasing sclerosis, confirming that the bone is fortifying and healing. To avoid this misinterpretation, standard protocol requires delaying definitive re-imaging until 6 months post-treatment. Because MDP reflects bone turnover, a worsening scan in the acute post-treatment phase is often the most direct evidence of systemic healing. The third false signal is critical, as severe pathology can mimic a clean, uniform skeleton. This is the Superscan. In this state, widespread systemic disease creates a skeletal environment that absorbs nearly the entire injected dose of the tracer. Comparing a normal scan to a Superscan reveals that the diagnostic indicator is actually what is missing from the image. The defining feature is the total absence of normal renal and soft tissue tracer clearance. The diseased bone has outcompeted the kidneys for the tracer. Once identified, the diagnostician must differentiate between metastatic and metabolic causes. Metastatic superscans, typically caused by prostate or breast cancer, show a different profile than metabolic scans. Metastatic scans present with asymmetrical, scattered hot and cold areas caused by localized bone infarcts or marrow displacement. A metabolic superscan, driven by conditions like hyperparathyroidism, presents with a characteristic uniform appearance. These scans show uptake extending distally into the arms and legs, often featuring an asymmetrically hot skull. In nuclear medicine, a completely uniform scan missing its normal soft tissue landmarks is often the final indicator of systemic collapse. The TC-MDP modality relies entirely on precise timing and optimal physiological clearance to generate a diagnostic image. Poor renal function or soft tissue noise can overwhelm the skeletal signal, making the underlying pathology indistinguishable from the background. Modern imaging offers a higher fidelity alternative, 18F sodium fluoride PET. F18 NAF PET utilizes the same physiological mechanisms of bone turnover, but offers significantly higher resolution and contrast than traditional planar scintigraphy. This clarity is achieved without the prolonged soft tissue clearance delays required by TC MDP. But despite this incredible technological advancement in image quality, the fundamental intellectual requirement for the physician remains exactly the same. Whether analyzing chemical artifacts, healing flares, or competitive binding in a Superscan, diagnostic rigor requires looking past the immediate bright spots to interrogate the systemic kinetics of the radiotracer.